Hello, this is Bob Falcone, CEO of the Columbus Medical Association and affiliates. Today we're going to be talking about COVID with our three adult system hospital medical leaders. We have Dr. Kreatsoulas from Mount Carmel Health. He's the Chief Medical Officer. We have Dr. Andrew Thomas from the Ohio State University Wexner Medical System, and he is the Chief Clinical Officer. And we have Dr. Bruce Vanderhoff, who is the Chief Medical Officer for Ohio Health, soon to be the Chief Medical Officer for the State of Ohio Department of Health. Gentlemen, welcome.
Morning, Bob.
So, Andy, let's start with you since you are our Zone 2 lead and have this information at your fingertip. How are we doing?
Not great. I think most folks are aware, based on the number of cases around the state. We've seen just a rapid rise in total cases here over the past, really since early October, but it's really accelerated here in November. We've certainly seen an increase in testing over that time, which does drive to some degree an increase in cases, but the increase in cases is far beyond the increase in testing. When you look at the positivity rate, it's a five-fold difference really between the rate of increase in positive cases versus the rate of increase of testing. So that is kind of something that's out there in the community. Oh, we're just testing more people, that's why there's more cases. It far exceeds any impact of increased testing. But obviously a lot of what Bruce and I work on relates to the hospitalizations that then occur for a subset of those patients. So what we're tracking across the zone is really an unprecedented growth in the number of patients in our hospitals. You know, if you go back to November 2nd, in our zone, which should go back, it's about 36 counties across the central and southern and southeastern parts of the state. And we peaked back in the spring at 356 patients with COVID in the hospital in our zone. On November 2nd, we surpassed 400 patients for the first time. That was the day before Election Day, just to put it in perspective. On that Friday, November 6th, we surpassed 500 patients. On Tuesday, November 10th, a week after the original, we surpassed 600 patients. On Tuesday, November 17th, just earlier this week, we surpassed 700 patients. On Wednesday, November 18th, we surpassed 800 patients the next day. As of this morning, we're sitting at 888 patients, and my gut is we're going to be over 900 tomorrow. It's basically a 38% increase in hospitalized inpatients in the past 7 days. And if you look back just compared to November 1st, 126% increase in the number of COVID patients in the hospital. And to think that was actually at a time when that was our new peak. So we're 126% above where our new record was on November 1st. So it's a major concern. We are to the point where the number of COVID patients, not just in Franklin County hospitals, but in hospitals all around the zone, are really going to start to crowd out other types of care. We've seen hospitals, every in the Cleveland Clinic down to some regional local hospitals that are starting to postpone elective, non-urgent, non-emergent cases. And I think it's going to be a major concern for us coming out of Thanksgiving. Going into the December holidays, if these number of cases continue to go up, we know that people are hospitalized 7 to 14 days after they become ill, have symptoms, or are tested. So if cases are going up like this, until we see them come down for an extended period of time, not just one day, we're talking 7 to 14 days of a decrease, we know hospitalizations are going to continue to track up. So it's a major concern. One of the other big differences compared to the spring, if you look back at the data in the spring, about 80 to 85, some days as much as 90% of the patients in our zone were in Franklin County adult hospitals. Now that's closer to 50%. The regional hospitals around the area are doing amazing work, keeping as many of these patients as close to home as they can. So, you know, hospitals that you maybe used to have 2 or 3 or 4 patients a day now have 20. You know, we do calls every morning at 9 a.m. and have over 20 hospitals and health systems report out on their capacity, their volume. We're moving patients between these hospitals really on a daily basis, far beyond everybody coming to Columbus for their care. So it's great partnership. It's great collaboration. You're a huge part of that, Bob. You and your team at COTS coordinate all this work for over 40 hospitals and health systems. So I know I'm not telling you anything you don't know, but I think the fear that I'm hearing in the voices of the hospital leaders around our zone is unprecedented. It wasn't what I was hearing 6 weeks ago or even 4 weeks ago in terms of the impact this is having on their nurses, their doctors, and obviously the impact on patients and their families when they get sick enough to be in the hospital. So I'll turn it back to you.
Yeah, when you look at the graphs, and I think we'll show some, the growth in hospital cases is exponential,
It is.
um, with no end in sight. I think many of us think that this is due to Halloween, which is really a minor holiday when you think about it.
Yeah,
When we
compared
talk
to
about
Thanksgiving or
Thanksgiving,
Christmas, you're
yeah,
correct.
when we talk about Thanksgiving or Christmas or Hanukkah, um, boy, we're going to see many more people if we don't get on this pretty quick. Bruce, I know Andy mentioned that um, a number of institutions are talking about delaying non-essential surgeries, and the four systems here in Central Ohio have talked, as have a number of other facilities in our region. Where are we with that?
Well, the systems have been working very, very closely here in Central Ohio to assure that as we inevitably move into needing to adjust caseloads and assure that at all times our systems are able to care for those who have the most acute healthcare issues and problems, that we're doing it largely in concert. So as of today, our systems, including the CEOs, were able to have, I think, a very productive conversation about, as we move into the next week and the week after that, what does that look like? One of the principles that I think the organizations have really landed on is a framework that we could have in common and yet would allow local flexibility so that we could be nimble and really be supporting each other, moving in concert, but not necessarily exactly the same way. Because, the levers that I might want to pull at Ohio Health and that would really help free up staff to be available to take care of patients might look slightly different than the levers that Andy needs to pull or that Nick needs to pull at Mount Carmel. So I think we're in a good spot in terms of our continuing the Central Ohio culture of collaboration and moving in concert. We're probably on the threshold of taking some of those moves, but we're also on the threshold of taking those moves in concert with our physicians who provide those services every day. And I think that's very important.
And by that same thought process, the other hospitals in the region, I think, are going to follow our lead. They're already cooperating, as Andy said, and I think they're going to follow our lead, which is, just amazing to me. You're talking about hospitals that haven't even talked to each other before, who are now communicating on a daily basis. Really pretty exciting.
It is.
As I look at the graphics, Andy, our hospital admissions are going up dramatically, but our ICU and ventilated patients are not quite as much. Is this a different disease? Are we better at treating it? I know we've got some new therapies that we've been using.
I do think we've learned a lot about this virus since the spring, Bob. Whether it's the interventions that we use from an oxygen delivery perspective, this heated high flow nasal cannula oxygen is incredibly valuable tool for our teams to avoid the use of the ventilator. I know what we've seen with remdesivir coming out over the summer in concert with early use of steroids, as well as in many cases, I think our teams still feel that convalescent plasma has been helpful in some of these cases. That combination of therapies used a little bit earlier, we know a little bit better which patients need it because they're higher risk of moving into needing a ventilator. We've been able to reduce the use of ventilators at Ohio State significantly compared to March, April, and May. And that's actually helping us in a variety of ways. One is the patients are actually doing well. The ventilator for some patients turned out to not be the typical salvation that you have with someone with respiratory failure. So if we can avoid the ventilator, that's great. It's also shortening our length of stay. Our median length of stay has gone from about 10 days down to about 7 days, which when you think about it from a capacity problem, if you shrink your length of stay by 30%, that's a smaller number of patients on any given day that you have in the hospital. which is beneficial. But our mortality rate has also improved pretty substantially. Some of the patients who got the disease early on are a little bit different than the patients who've gotten the disease now because of nursing homes and prisons and other things. But in general, we think our mortality rate's down by almost a quarter compared to what it was back in the first couple months of the disease. So a lot of it's really hardworking docs and nurse practitioners and respiratory therapists that have, just continued to learn, pouring through the data, pouring through our own practice to improve. Infectious disease docs that have been just invaluable to all of us in their consultations that they do. And then some of the new science has been incredibly helpful with the medications and just the learning that we've had since the spring. So.
Nick, we've talked a little bit about where we are today and where we're going, and the fact that we're doing a much better job of, I think, saving lives in patients with COVID. I know today when we talked, you were particularly passionate about Mount Carmel's approach to looking at decreasing elective procedures. Your surgical staff is really deeply involved. Can you tell me a little bit about that?
So I have a great surgical staff here. We understand, I think we all understand the difficulties with the surge occurring, and our surgical staff, medical staff, is well aware of that and have been very collegial with their approach and wanting to help. They know that they're going to have to either move some surgeries out to surgery centers or delay surgeries, postpone surgeries over the next several weeks as we try to see where this surge is going to occur and how it's going to occur. Someone told me today, there's a downtick. Well, a trend is 7 days. So we have a long way to go to see what downtick or what uptick is really applying. So we met with our surgical teams last evening, our chairs, and they were very receptive in trying to either postpone or move some of the surgeries out to the ASCs or even to New Albany. And we're trying to see if we can get a lot of the work done in the surgical suites and then move them to the PACU and then home. So we limit the amount of nursing complement that we need. Again, we're trying to move that nursing complement into the hospitals.
Yeah, and the key here, I think, for you and for all of our systems is we're working in concert with our physicians. We're not telling them what to do. We're asking them how we go about it.
Well, they made it very clear last evening that they know how well all four systems work together. And they want to respect that relationship.
Yeah, and it's interesting that Children's Hospital has also stepped up, even though they don't take care of the same patients we do. They're willing to take patients up to 26 years of age, which may be a real help if we continue going down the path we're going. One of the big things I hear from every institution I talk to is issues with staffing. It used to be PPE, that's done, but now we're having issues with staffing. Bruce, I know you've pulled together most of the ID people in the state to talk a little bit about what we do with repatriating COVID positive but asymptomatic employees. Can you talk a little about that?
Yeah, we've recognized as these numbers have just escalated in such a dramatic way, exponentially, as you mentioned, that the impact that this is having in the community is being felt by our staff, by our professional staff in our hospitals who are not living, in bubbles. They're living in the real world. And so outside the hospital, our vital staff are being exposed to individuals who are becoming positive and yet are themselves asymptomatic. The problem is it's resulting in huge quarantine numbers for us. Today at Ohio Health, we've had more than 500 people needing to be on quarantine using the historic conservative CDC definition of quarantine. But the CDC does make very clear that in a crisis, and I think this clearly is a crisis, there are safe and effective alternatives that can be applied. And so this week, the infectious disease community with representatives from nearly every large institution around the state has convened and has been looking at this question. They've, of course, highlighted the fact that we have some very large and respected institutions that have already gone down the path of a crisis approach and have had very safe outcomes in taking an alternative approach to quarantine for asymptomatic individuals in healthcare. And they've underlined the fact that this really illustrates just how effective masking and the use of PPE really are in blocking the spread of this virus and protecting people from COVID-19. But I'm hopeful that today we're having a follow-up meeting. I'm hopeful that as a result of that meeting, we'll be able to, as we head into the new week, share a consensus from the ID community of the state of Ohio that can be utilized by healthcare institutions across the state.
That would be great. Even if you repatriated a quarter of those, that would make a huge impact between all our systems where we have lots and lots of people out. Andy, we've got light at the end of the tunnel with a vaccine coming. Who's going to get that when it gets to us?
Well, to some degree, Bob, the vaccine prioritization is being driven by the federal government, who obviously is kind of in charge of the process, and to some degree by the state through the Ohio Department of Health. But really, it's going to follow some of the same principles that we've used for other things throughout the pandemic. It's this concept of allocation of scarce medical resources, where we know we don't have, whether it was remdesivir when we started with that over the summer, or now it's bamlanivimab. Try and say that 3 times fast, which is another medication. The ventilators, when we were worried we weren't going to have enough ventilators, which obviously we end up not having that problem here. But it's the concept of how do you take a really limited resource and use it in the most effective way for the most value. And then you, as that supply chain changes or increases, you liberalize sort of that access criteria for it. So the good news, I think, for many of the folks watching this is that healthcare providers are going to be amongst the first to receive the vaccine. But now most hospitals, along with OHA and others, are kind of in this phase of trying to determine which healthcare providers are most at risk. So I think all of us are working on our own prioritization scheme based on how our organization looks and runs. I think there's no doubt that an ICU nurse or an ER doctor, or even frankly someone in environmental services that works in those spaces, is going to be more likely to be in the kind of phase 1A of the vaccine distribution. People that work in an ambulatory clinic, certainly with direct patient care, would be kind of in the phase 1B. And then, people that work in the back office that never really encounter a patient, they're going to be lower on the prioritization level. And then, of course, the next group to talk about really are high-risk patients. So the elderly, people with high-risk medical conditions, they're currently getting cancer treatment or have other immune suppression. Those are folks that are going to be really nip and tuck with those high-risk healthcare providers for getting the first rounds of the vaccine. Now, what we do know is we're clearly just not going to get enough early on to make this work. I believe the last week the governor announced he thinks at this point we've been told Ohio's going to get around 30,000 total doses in the first round. We'll see what actually comes. Part of that may depend on which vaccine gets approved first. But 30,000 doses in a state of 11.5 million people is not going to go very far. So, but the good news is once that FDA EUA approval happens, the companies have actually already been manufacturing these vaccines, assuming they will be approved. So we do think we will have kind of a continued shipment of vaccine over the course of the winter. So each of our hospitals, in fact, we just had a webinar on this last week where the 4 local health systems presented kind of our strategies toward vaccine deployment. We'll be continuing that discussion the week after Thanksgiving with another webinar. We're all trying to partner together to learn how do we store the stuff? How do we get it from, being delivered into somebody's arm? How do we document it correctly? There's some strange things with this one in that obviously most of the vaccines now we're talking about it being a 2-dose strategy. So someone's going to have to come back in 21 to 28 days to get a second dose, but they need to get the second dose of the same vaccine they got the first time for it to be optimally effective. So there's a variety of wrinkles to this that are going to be a little bit different than most vaccinations. It's certainly not as simple as getting a flu shot. But at the same time, I think we are up to the task. I think all of our systems have, between pharmacy and physician leadership, nursing leadership, employee health, we're all getting arms around this to make sure it's done right.
And when you think about it, we'll have plenty of time to sort this out. I don't see the general public having access to this before the summer. Does that sound about right to you guys?
In terms of low risk patients,
Yeah.
that may be true. My hope would be that we'd be vaccinating kids before school starts next fall. But I think you're right. It's going to be high risk patients and healthcare workers for the time being.
Yeah, Bob, I think it's probably hard right now to make accurate predictions about how quickly this will roll out. I'm encouraged, to be honest, about how quickly the manufacturers are talking about potentially rolling out these first two vaccines. So we'll have to wait and see. But I think that I'm cautiously optimistic that that timetable may be a little bit faster than this summer.
Yeah, same, Bob, hopefully.
Well, let's keep our fingers crossed. I wanted to thank our team for their time today. Dr. Andrew Thomas from the Ohio State University Wexner Medical Center, Dr. Nick Kreatsoulas from the Mount Carmel Medical Center, Dr. Bruce Vanderhoff from the Ohio Health System, and soon to be part of the Ohio Department of Health. Best of
We're
luck.
very proud of you, Bruce.
Go Bruce. Go Bruce.
Thank you very much.
Go Bruce.
Thanks, guys.
I just want to add one thing, Bob.
Sure.
We have a lot of very selfless healthcare people, associates, physicians, nurses, respiratory therapists who come to work every single day knowing that they could be putting themselves at risk. So they're really the heroes here. We want to stress that we have just an incredible team of human beings that are caring for people in a very trying, very difficult situation, especially with the surge occurring. I just want to stress that. Even in the offices, there are a lot of physicians, nurses that are caring for our COVID patients in the offices too. So kudos to everybody. Kudos.
Agreed.
Amen to that. Yeah, well said.
Well put, Nick. So I'd like to close with this ask of our medical providers who are watching. People aren't taking our advice, but they will take your advice. And if you have a direct one-on-one conversation with your patients that they should wear a mask, they should socially distance, and they should avoid gatherings outside their household, probably through the holidays. It's a tough message, but they may listen to you. So far, they're not listening to the rest of us, and the results are as you see them. Way too many people in the hospital, way too many people with COVID, and way too many people impacted by this terrible pandemic. So with that, this is Bob Falcone for the Columbus Medical Association. Till next time. Thanks, guys.